It's now 1 o'clock. Thank you very much to all of you who have come to this important and probably a seminal webinar on geriatric neurosurgery. I think Dr. Schmidt and Dr. Villars from Toulouse, they have done exceptionally good work with as far as I can see, the first issue on geriatric neurosurgery, which was published in Neurosurgery Focus last year, and congratulations to the Neurosurgery Focus and Dr. Caldwell, I think, who's the editor of that journal. The geriatric neurosurgery is also well developed in Japan and Korea. They have not only geriatric neurosurgery societies for those respective countries, but they have journals and conferences on geriatric neurosurgery. I hope that we will get their practices and see how they are doing as well in future. I think, as we all know, geriatric neurosurgery is getting more and more important. And whereas we have got a specialty for pediatric neurosurgery, I think it's also important to have a specialty for geriatric neurosurgery, where those neurosurgeons' interests are particularly focused on the elderly and improve their outcome. If you look at, if you say that the age limit for geriatrics is above the age of 65, then if you look at the two of the powerful leaders in the world at the moment, whether it's Biden or whether it's Putin, they are all in their 70s. And also in terms of Biden aging towards 80s. So the idea that someone above 65 is past is pretty much out of date. And I think it is beholden on neurosurgeons to forget the past assumptions and try to improve their care, particularly as we also sooner or later will get to that age limit. So it's on our own interest as well. This is a video with the permission of the patient and family. I'm going to show you. This is a gentleman, a patient of mine who's 75 years, who's in his 70s, and who was in a very important profession, and he was a flight coordinator, or the flight traffic coordinator, and at top of his game. And then his mobility and his cognition had deteriorated. And then he was diagnosed with normal pressure hydrocephalus, and I inserted a VP shunt. And when I saw him on Friday in my clinic, he was a completely different man. His face was very bright, sharp, thinking and talking as he was normally he would talk. And he's now, as you would see in this video, he is so you can see how his life has been transformed, and they are going on holiday to Mallorca tomorrow. So you can see how patients can improve if we only puts effort. So it's real honor and privilege to invite Dr. Schmidt, Eric Schmidt, and Dr. Helene Villars from University of Toulouse. Dr. Schmidt is a neurosurgeon and Dr. Villars is a geriatrician. And it's important that in this field of geriatric neurosurgery that we work very close together, because in fact, sometimes the surgery is the easy part, and the care of the patient as a holistic is actually the harder part. So I think it's a very important multidisciplinary area. So without further ado, if I could please invite Dr. Schmidt to kindly first of all give his talk, and then Dr. Villars. You should be able to share your presentation. Thank you.
Thank you, Naren, for this nice invitation. First of all, you mentioned the neurosurgical focus issue, and I have to pay respect to Mark Hamilton, my colleague from Calgary. And this is a joint work. We all together designed this focus, neurosurgical focus issue, and I have to mention his name when we speak about the neurosurgical focus. Thank you one more time for the invitation. We're very happy to explain our view of geriatric neurosurgery. And I'm a neurosurgeon here in Toulouse, and I'm very much interested in various conditions. As you mentioned, hydrocephalus is probably one of my major clinical and scientific approach, but in broader sense, I've been involved in many other conditions. And I understood that the collaboration with the specialists in the process was very important.
Sorry.
Was very important, and the collaboration with the other teams is really a key issue. And Helene, with whom I'm working on a daily basis, is going to present herself.
Thank you very much for this invitation. It's of course a great opportunity for me to share our geriatrics concept and knowledge. As previously said, I'm a geriatrician at the Toulouse University Hospital, also in the south of France, and I have also a PhD in aging science, which is called now geoscience, which is a new field of research. So I'm very happy to talk and to share my experience with you.
Thank you very much.
Okay, then yes, of course. This is the overall presentation. I'm going to give a brief introduction of the concept. And then we're going to discuss about the epidemiology of aging and geriatric medicine. And then I will try to zoom on an update in neurosurgery in older people. Then we'll discuss about expected risks in neurosurgery among older people. We'll try to define the goal and the means to achieve the goals. And ultimately, we'll try to propose a take-home message. This paper was published in 1987. By the team from Detroit. And this paper is probably the very first that clearly described what is happening. They analyzed, that's why in terms of history, it's very interesting. You see that they analyzed the trend in aging population in their words. And they clearly showed with detail that the admission of a patient in a ward was increasing. And you see the numbers. Unfortunately, I cannot see it on the screen, but you can see, and he was describing the profile of those elderly patients. And interestingly, he was also mentioning that patients over 85 were only 4% of the geriatric population. There was really seldom very old patients. But the very interesting part is that they understood, and it's very important to read this paper from 1987, that the author said that in the past, older age was believed to be a contraindication for surgery. But now we know that it is important to go further, and since life is expanding, we have to accept that this arbitrary age limit is an old approach. And the last sentence is very interesting and very relevant. They say that age alone is not a barrier to neurosurgical treatment, and when other factors are adequately managed. And as Naren initially mentioned, we are facing an older population, and we have to understand what actually drives this. This paper, more recent from 2010 or 11, from the Paris University, describe more or less the same process. But if you have a look to PubMed, and which is an interesting metric, if you enter neurosurgery and elderly, I did it yesterday, you see that there is a large number of issues raised. But if you enter neurosurgery and geriatrics, you see they're really seldom paper. And just I make this small, simple graph to describe the trend when you enter neurosurgery and elderly, when you enter neurosurgery and old person, and when you enter neurosurgery and geriatric. What does it mean? It means that the fact that the population is aging is clearly related in the published literature. But the culture and the fact that we take care of patients according to the knowledge of the geriatricians is lagging behind. And this is an important message. And if you compare, for example, to neurosurgery and child and pediatric neurosurgery, you clearly see that the trends are following the same way. Why? Because pediatricians and neurosurgeons probably work in close collaboration, and in the published literature, you clearly see that the trend is really similar. Then the parallel with pediatric neurosurgery, as mentioned, Naren, is very relevant because pediatric surgery is the first neurosurgical specialty and is developed to address the unique requirement of young patients. The very important thing is that transposing the adult rules to different populations must take into account and mostly ignore fundamental differences. That's why we need specificity and the uniqueness of young people or young child to be taken into condition, and we need a multidisciplinary approach in a pediatric-centric environment. We need to focus on patient and family, and we need the care to be multidimensional, and the goal is to improve the outcome. When you see this definition, I think is acceptable for pediatric surgery, you just have to change a few letters. And you understand that geriatric neurosurgery is a new neurosurgical specialty. And it's developed to address the unique requirement of all the patients. And transposing the other rules to all the patients ignore vast and fundamental differences in all the patients. And the specificity and uniqueness of all the person has to be taken into account. A multidisciplinary approach in a geriatric-centric environment is required, and the focus should be on the patient and the family, and the care should be multidimensional, and the goal is to improve outcome. You see, there are some similarities that helps to understand why we should promote the concept of geriatric neurosurgery in a broader field and understand whether this could be more precisely defined. And now I pass to Helene.
So as previously said, we are facing a demographic transition, which is called by demographic transition of aging. The worldwide population is aging, especially in the Western country, United States of America, Europe. And in 2022, there are 900 million people over 60 years old. And in 2050, there will be an expected number of 2 billion people. So it's the first time in our society in which the old age is so visible. It's a major anthropological change. And the healthcare system and social healthcare system are facing this challenge in how effectively address this issue. And of course, every medical discipline are facing this challenge. If you see, for example, the European population, you see in yellow people between 15 years old and 64 years old. And you can see that this population is dramatically decreasing in the following year. And the population over 65 years old and over 80 years old is increasing. So it's a case in Europe, also in France. I have put maybe the slide of the case of France, because life expectancy is increasing, and that's a good news, and it's a chance for us to have life expectancy to increase. But it leads to a question of sustainability of our healthcare system and the necessity for them to adapt, to be tailored and to to change, to face this challenge. In France and in other countries, there is a difference between women and men, a difference of 6 years. And what is interesting also is that this population of 65 years old and over are suffering from at least 3 conditions in a third of cases. And a third of them are also suffering from neurocognitive impairment, from mild to severe impairment. And there is a proportion of them that are suffering from both. In France, for example, you can see in red women and in blue men, the generation of baby boomer is aging, and there are numerous and young people. As you see, it's not a pyramid anymore, it's different. And our healthcare system has been designed for acute diseases and not for chronic condition, for dementia, for neurocognitive impairment. So it has been overlooked. The dependency has been a bit overlooked. So that's why it's important to have this context to pursue our presentation. Just a slide to talk about the geriatric medicine, which is a new field of medicine, 50 years old, after the Second World War. It has been designed to take into account the intrinsic vulnerability of older people of old age. And it's now changing. It's moving toward a more preventive approach, such as oncology or cardiology did a few years ago. Now geriatric is moving toward prevention and toward a more integrated care, which we will talk about later. Prevention is now an outcome. It's now an outcome of research, for example, for us, for our community. And healthy aging is the main outcome we pursue, maintaining quality of life, maintaining intrinsic capacity. I just need to talk about autonomy and dependency in order to pursue. Autonomy, in our field, we talk about functional autonomy and not autonomy in general, which is much more self-rule, self-determination. Here we will talk about the functional autonomy in daily living, for example, for eating, walking, dressing, being alone, and to be autonomous. I'm sorry. It's different from dependency. Dependency is a need for a person to be helped for this activity and is related to functional limitation, which involves a balance between an individual inherent physical abilities and his or her environment. Different from disability, because a disabled person can be autonomous with, for example, technical help. The two concepts are very relevant in geriatric medicine, and we need to have them, to take them into our mind and to pursue our presentation. Just this slide to talk about our societies, international geriatric societies, European society, and of course the French geriatric society. So it's a new medicine, but also a new field of research. We are all growing old. Aging is a chance for a human being, it's not a disease, of course. You can see on your right the vast majority of people which are on the trajectory of healthy aging, which are independent at home with minor diseases, with less than 1 or 2 chronic conditions, which are aging normally. You can see on your left a more pathological aging pathway. 5% of people are dependent, suffering from dementia, requiring hospitalization, nursing home entrance and admission. And between the two concepts, there is a concept of frailty, which has been developed in the last years. It's a condition characterized by a loss of reserve and a failure of physiological mechanism. It's a condition that leads to a vulnerability to a range of adverse outcomes, morbidity, mortality. And some consider it's a continuum between healthy aging and pathological aging. And what's interesting is that this state is reversible. You can see that if you can put the next slide, 30% of people are considered as pre-frail, we will see the definition, and 10% are considered by frail. And if detected, strategies can be implemented to reverse the process and to go in a more normal trajectory of aging. The definition is based on the Fried model, but also another model, another phenotype we'll talk about, but the Fried model is widely used. A person is considered as frail when he or she meets more than 3 of these following criteria: an intentional weight loss, self-reported exhaustions, muscle weakness, walking speed in the lowest 20%, and a low level of activity. If a person meets 1 or 2 of these criteria, we can consider him or her as pre-frail, and this is a reversible state. There is also another model of Lockwood with 9 stages, from very fit and well to terminally ill, which is also used in clinical routine. But the Fried model is more widely used in research, for example. That's important to consider because if a surgical stress occurs in an autonomous person, as you can see in the slide, the person can go below the threshold and became frail. But if the same surgical stress is experienced by the person already frail, then with a poor reserve, he comes below the threshold of dependency and goes in a pathological trajectory of aging. That's really important to take into account. You can see the normal trajectory of aging, normal, which is sometimes called successful aging. You can see it in the literature. And you can see in red the curve and the trend with those stress, with those we previously described, and that lead to disability. So it's important to consider that fact, because strategies can be implemented. And we will see in neurological wards, on the neurological older patient, neurosurgical, what can be done to prevent this side effect. And lastly, I will talk about the concept of geriatric syndrome, because it's very important in our field. It's a term used to describe a group of common health conditions in older people that do not really fit in the disease category that we have learned, because they have multiple causes, multiple etiology, and multiple pathogenesis process, but the clinical outcome is still the same. For example, falls. If you consider a fall, the fall can have many causes, for example, anemia, for example, Parkinson's disease or hearing impairment. But in the end, you still have a fall. And that's an archetype of the geriatric syndrome. Falls, delirium, for example, is also a geriatric syndrome, malnutrition, polypharmacy, and iatrogeny. And that's a concept we try to comprehend with many tools, geriatric tools that we will talk later. So just a slide to finish, to see that geriatric syndrome and frailty are sharing risk factors. For example, older age, over 90, cognitive impairment are shared risk factor between geriatric syndrome and frailty in itself. And for some, frailty is also geriatric syndrome for some researchers. That's it. The last slide to say that geriatric medicine is moving toward prevention and is also moving toward a more integrated care, patient-centered approach with the primary care provider, the advanced nurse, the domestic health in the area, the organization of the healthcare system of this area, and also in the policies of the country in which she or he lives. It's important to consider that the care provided to another adult depends on all these elements and is integrated now in a patient-centered approach. And for example, the World Health Organization developed the ICOP program, Integrated Care for Older People, to monitor 6 major functional capacity: nutrition, cognition, vision, hearing, locomotion, and psychology. It's a program supported by every actor, health and medical, social sectors, and the older adults and their caregivers to be monitored and to be helped to stay in a trajectory of normal aging. So we'll talk now about our older patient when he experienced a neurosurgical stress and a neurosurgical approach.
Thank you, Helene. I'm going to give you sort of quick overview about brain problems in elderlies. We'll discuss about head trauma and diffuse axonal injury, stroke with ischemic and hemorrhagic stroke, subdural hematoma, tumor, and hydrocaphy. I start with trauma. I'd like very much to start a presentation about trauma with this slide that says that elderly fall is a new trauma epidemic. And if you go in every in emergency department, wherever you go around the world in modern countries, you see that there are more and more elderly that fall with head trauma. And this was clearly identified in the epidemiology. We clearly see that a patient with the young fell, but the older also fell. And if you have a look to what happened when you try to understand what was the origin of why the patient goes to the hospital, you see that fall is clearly a key parameter in the young population, but also in the elderly population. And if you have a look to the mortality, clearly that you see that mortality of fall is really limited in childhood, but you can clearly see that fall and head injury is a major component of mortality, of post-traumatic mortality in elderly. We also know that mortality is clearly associated with severe head injury. In elderly, this paper nicely demonstrates that elderly, when they are admitted in a neurosurgical center, can be treated. When you see that the older they are, the lower first that the number that gain access to a neurosurgical center, also in intensive care. And the trend is to adapt and to take also in account the age. The trouble is, why should we define whether an older patient, an 80 years old patient, should go in an intensive care or in a neurosurgical round? This is a daily issue. And we know that the mortality is higher. It's the Philistine process. The older you are, the more frail you are, the more probable you die when you get head trauma. But the way we manage the patient also has to be taken into account. And you see that those who are older do not gain access to intensive care. And ultimately, it leads to a condition where the mortality is increasing. This recent paper shows that the mortality after subdural evacuation is increasing depending on age. Then we have to be aware, should we treat or should not we treat? There is no clear cut, there is no clear definition. But this recent paper I strongly recommend to understand the impact of frailty on outcome is very relevant. You have here the probability of the frailty index, it's a rock, and here on the left, on the y-axis, you have the probability of having a worse outcome. And worst outcome in light blue is dead, and in dark blue is healthy. And you see in the young population, you clearly see that frailty is not a major impact on the probability of worst outcome. But if you grow old, you clearly see there is a trend, and the population over 65, clearly you see that frailty has to be involved in the understanding, and they develop index or scales like a combination center TBI and frailty index to better characterize. And it is interesting, this is a very good example that two worlds, the world of neurosurgery, intensive care, meets the world of geriatric culture to better characterize those elderly and to better treat and to better take care. Hematoma and stroke are in a way rather similar, and I will quickly explain that we know that hemicraniectomy in all the patients with, for example, stroke, we know that those who have been operated on get better results, like a tautology, self-replating process. We know that if we improve the mechanical condition of the brain, if we improve the condition of the biochemical condition of the brain, we also improve the outcome, and it is lasting a longer time. And we know that even in elderly, performing an aggressive procedure is relevant. But one more time, we should not always operate every patient, but we have to take into account that age per se is not sufficient to say I go or I do not go. And the go-no-go process has also to be put in perspective of condition. Subdural hematoma. I like very much this paper that describes the project, the sort of understand with mathematical model what is going to happen in the future. And you clearly see that during 2012 period, chronic subdural hematoma is clearly increasing. The incidence is roughly close to 8 per 100,000 person. And we know that is going to increase. And they estimate that the incidence is expected to be 120 in 2030. At that time, 60 subdural hematoma will be ending in our world. And roughly, we have to expect within less than 20 years to double the amount of subdural in our word. This paper, this more recent paper, says exactly the same, and even it gets worse because the estimating in 2030 is not 100, it's more than 170, and clearly there will be an pandemic of subdural hematoma in our wards. We have to understand this. We have to define an algorithm. We have to collaborate with specialists in old age. And should we operate subdural in a non-Nigerian? It's difficult, but it has to be done if we understand clearly the condition of the patient. One more time, we have not to bluntly follow the clinical sign, the clinical age or the MRI of the CT scan. We have to take a perspective, zoom out, and consider the large frame. We are lucky because we have good studies that show that how to handle with. We know that dexamethasone is not actually improving the outcome. We know that draining subdural is relevant, and it has been clearly demonstrated with RCTs. And this is very helpful for the neurosurgical community to deal with those patients. And we also have modern approach with middle meningeal artery embolization. This is definitely a very interesting approach since it is less aggressive than burying a hole, and it looks promising. And in other way, we have an armamentarium to treat subdural, but we have to, one more time, consider the big frame and be cautious. We know that this, after subdural meningeal embolization, we improve the control, but other study and a lot of studies around the world underperform. Tumor is that in the last issue of neurosurgical focus dedicated to all the patients, there is clearly a trend to better characterize and following the movement of geriatric oncology. It means that it is slightly different to manage a patient which is 60 years old and a patient which is 80 years old. And if you have a look to your ward, you probably see more and more elderly with brain tumors. We know the epidemiology, we know that it's a big issue, and we have to be very aware that there are methods to understand. We know we have literature to demonstrate that there are possibilities, it's possible to operate on, but operating on a patient should not be performed solely. We need a dedicated team and we need a collaboration because, of course, you can operate whenever you want, but if you have a close look to the condition of the patient and in his condition after the surgery, you have to be aware of the risk and discuss with the family, with the anesthetist, with the geriatricians, and with all the staff around your ward. We know also that radiation therapy is helpful, but we know all the trend and the unfortunate patient face when we have the glioblastoma. About meningioma, I'm going to show only this slide from the team from Chris Bowers. I like it very much because Chris is very interested in frailty, and he measured in his last prospective study of meningioma frailty, and he clearly demonstrated that frailty was associated with the length of stay. It means that the longer the patient stay, the more frail they are. The discharge location is also dependent on frailty, as well as the reoperation rate. And it's a very interesting approach that it combines expertise and it's able to go deeper in the optimization. And the idea is to operate most of the patient, but to tailor, as Helene said previously, the indication in order to be able to optimally organize patient care. Hydrocephalus, at least in my understanding, the most fascinating neurosurgical condition because we address many issues, and fluid mechanics within the brain is fascinating, as mentioned Naren in his nice introduction. We know that vascular dementia, Alzheimer, hydrocephalus, Parkinson's disease have been clearly defined as a classical nosography, but we know that there are lots of interplay, and we have to consider that a patient with neurodegenerative disease looks like this. And the more I work clinically and scientifically, the more I'm convinced that, and there are evidence to support this, that we face this reality. And a patient with neurodegenerative disease has many factors: vascular, small clottings, minor strokes, protein abnormality, protein control dysfunction, and domination neuron loss, and CSF problems and intracranial fluid dynamics alteration. That's why in the field of neurosurgery, hydrocephalus is a wonderful model to explore and to collaborate with neurologists, geriatricians, to understand deeper what happened. And when we try to use the algorithm we have been published to define whether a patient should operate it on, because Naren shows nicely the patient that dramatically improved because he carefully selected his patient. And to do this, we have also to be aware that fluid dynamics can be characterized, and the patient which is treated has to be understood also as a mean or as a system where biomechanics is altered. That's why we perform infusion studies or just a dynamic exploration, which is rather straightforward and helps a lot to characterize. I'm also performing some research, and just to mention one recent paper from Alexandra Vallée, and she combined face contrast MRI and infusion test to obtain an index of elastance. And she nicely demonstrated that elastance was correlated to frailty. And this is interesting to understand that this Geriatric concept of frailty that Helene nicely described previously is in fact also linked to biological physical properties of the brain. It's hidden in the skull, but clearly the stiffer the brain, the more frail the patient. And this has to be explored further. Explore further with models, but also with new approach, understanding what is the bowel flow, what is the diffusion, and also understand whether the lymphatic pathway is involved, and also to characterize whether convection, bowel flow, or diffusion is prominent. And models clearly show that at least diffusion is overwhelming over convection. Then a lot of issues, lots of statistical questions, very interesting, and in that field, neurosurgery has to be involved and put forward. And ultimately, ethics. This it's online, so it's available online. This very nice paper from Mark Benstein and Laureen Hatcher. They try to define what is the ethical framework. They deal with autonomy, justice, consent, fertility, but they also have a look of over under excess of care, beneficence or non-beneficence, and utilitarianism or deontology. But I wanted to quote the last sentence, their conclusion, because it's very relevant, and I like very much what they wrote. The global demographic shift to an older population has led to an emergence of a new field of geriatric neurosurgery, but I think a clear ethical framework and knowledge of the ethical issues are inherent within the field, will be of utmost importance to deliver the highest level of care to the unique population of geriatric population and geriatric neurosurgical patients. Then we have to be aware that ethics, understanding what actually drives whether we have to make a decision. That's why also geriatric neurosurgery is so interesting, because it's not solely a very skillful performance or technique. It has also, I would say, a moral, more humanistic approach, because taking care of the most vulnerable among us mandates a conviction, understanding, thoughts, and don't be too close to a sort of strict rules, but adapt, and above all, take care of the human being you're in charge of. And then we skip to the risks. of neurosurgery among all the people who will share this presentation. I'll start with this very interesting paper published recently in the JAMA, and they try to understand what are the risk factors of the patient, and they clearly see that in non-geriatric patients, what actually has an impact on the outcome is, as you as neurosurgeon know, emergency process, sepsis, infection, cancer, or complication. But interestingly, in the geriatric population, you clearly see that what actually drives the outcome is fall, preventive use mobility, in the patient get gait problems, malnutrition, delirium, pressure, a problem with the discharge. I mean that you when you zoom out, you clearly see that in the larger frame of geriatrics. That's why, one more time, when you try to take some distance, you understand that we combine our expertise because we combine our view in the same reality.
Thank you, Ray. It's true. For example, delirium is very common. Delirium is a reversible condition, very common in neurosurgical patients. Almost 50% of persons experience delirium during their stay in neurosurgical wards. So it's important to be diagnosed because it is reversible, and there are strategies to prevent it or to lessen its consequences. It's developed in a short period of time, within hours or a few days, and it is characterized by an attention span, the fluctuating course, disorganizing thinking. And you have tools to diagnose, for example, the confusion assessment method with 5 items: acute onset, fluctuating course, inattention, disorganizing thinking, and altered level of consciousness. What is important is there is 2 forms of delirium: hyperactive with agitation, restlessness, but also hyperactive delirium. And this form is very common in geriatrics. So you can see a person, an older person, that is only sleeping during the day, that is not very much agitated, not very much with delusion, with aggressiveness, but you have to think about delirium because there are strategies to prevent it. So, thank you. The strategies to prevent it are very simple. You need to reorient the patient, the frequent orientation. You need to have sleep management strategies and revision of the medication, especially pain medication and especially psychotrops. You have to include the relatives also in the process. You have to pay attention to the electrolyte management and the nutrition and hydratation state. You have also to ensure that the patient has glasses and hearing devices to take care of the vision and hearing impairment. And of course, early mobilization. That's important to detect delirium because 50% of people experience this outcome. And you need to train your staff, train all the staff, nurses, anesthesiologists, the surgeon, of course, to join the expertise of geriatrician you can have in your unit to implement early strategy. It's important because each day counts, in the delirium process. So that's really important. There are risk factors, but also precipitating factors. For example, physical and psychological stress. For example, the postoperative neuroinflammation, the lack of preventive strategy, but also use of restraints, for example, which we fight against, of course, geriatricians. And risk factor, precipitating factor, the need to be diagnosed and strategies to be implemented in order to fight against loss of autonomy, nursing home placement, of course, increased length of stay also, and increased cost, and yes, of course, mortality. So delirium is part of a more global problem, which is hospitalization-associated disability. We knew that older person hospitalized, especially in surgical and especially neurosurgical wards, can experience hospitalization-associated disability. Which is important is to assess the 6 items of functional status: bathing, dressing, eating, walking, transferring, and toileting. You have to train your staff to identify the risk situations on this item and to pay attention, for example, to encourage the subject to do him or by herself the toilet, the dressing, the strategies to prevent delirium that we previously said, to pay attention to avoid urinary tract sondage, to pay attention to assess frequently, the benefit of scopes and of oxygen therapy and tube feeding, because the person stay in bed when with these devices, to also encourage transferring and walking by him or herself, of course, to optimize medication, pain, and psychotrope, to adapt the quality and the caloric intake to fight against hypermetabolism, which is frequent in surgical conditions, and to fight against malnutrition, and of course to anticipate very early the discharge, and to include the caregiver in the whole process.
For the presentation, the collaboration with the anesthetist is very important, and to thank him to emphasize the importance of François Lavas, which is one of our colleague anesthetists. And two slides, from his side, and he just says through this slide that the burden clearly is an impact on the outcome. And when you try to expect what are the goals to achieve, we have to take into account that few things are important, especially quality of life. And this is your turn.
Of course, we need to avoid adverse effects, as we said. We need to focus on maintaining autonomy, improving autonomy, but also maintaining the quality of life, which is defined by the World Health Organization as an individual's perception of their position in life in the context of the cultural and value system in which they live, and in relation to their goals, patient standards, and content. It's multidimensional, it's a relevant criteria, and a key patient-centered outcome. The WHO developed scales to measure it. It's very difficult, of course, to measure it, especially in older adults. But we need to keep in mind that the quality of life of the person is really, really important to be assessed and to be pursued as a goal of care. You can see the scale of the WHO, the World Health Organization, especially developed for older people. And the last point is the importance of caregiver, because caregivers are helping the dependent person for this basic daily living activity that we described, and the choice to age in place and to age at home is shouldered, in fact, by caregivers, which are spouses or the adult child caregiver of our patient. And we need to take into account the impact of the caregiver role on the health of the person. So there is a need to help caregiver to maintain their role.
Then you've seen Helene explain the goals, but how can we achieve the goals, and how can we use tools? There are a few tools. Helene, it's your turn.
For example, the comprehensive geriatric assessment, which is well known in geriatric medicine, which helps identifying geriatric conditions and geriatric syndromes, which is done by the means of validated scale, for example, the MICOG, the confusion assessment method, for example, the MMS scale. And the geriatric assessment is a diagnosis process, but it's also used to the management, to assess the management. It measures components can vary from one patient to another. But what is important, it is a tool to help risk stratification, maybe to screen the patient and see if he or she can experience the surgery, what can be done after the surgery in the per-operative and post-operative period, what can be done to prevent adverse effects that we talked about, and to finally choose the best way, the best care for the person. For example, it is used in oncology also. It's a great tool now to the decision process of chemotherapy or surgery or radiotherapy in older adults suffering from cancer. So it's widely used now in cardiology, also oncology, and I think it would be great to be widely implemented in neurosurgery.
If we have a look to the global pathway, we have the continuity parallel, which is interesting, and I would like to mention Professor Jacques Baudert, which is a geriatrician in Paris, and is leading the orthogeriatrics department. And they're upfront, really. And just this slide to explain that a patient with hip fracture, for example, that has to be operated on, needs a specific environment and dedicated team. We need to analyze clearly what are the original, where the patient comes from. We have to shorten the time between the trauma and the surgery, and the postoperative complication has to be managed in a way to reduce the time of stay. And severe postoperative complication has to be clearly identified. Then the concept of pathway is very important, and the geriatric pathway is a race against the clock. And this is a slide from Jacques Baudert, and it lastly demonstrates that geriatric pathway is not geriatric specificity, but it is adapted to the condition of the patient that mandate all person or specialists that are involved in, from the anesthetist, from the people from emergency, the surgeon, the caregiver, the paramedics, all the people should target and use the tools that have been developed by geriatricians in order to characterize and optimize the pathway. And one more time, when you mention the problem of hospitalization, we have to be aware that there are things which are avoidable, meaning that there are main causes of hospitalization-associated disability, meaning that a patient in your ward, irrespective, one more time, of the performance of the surgery, is going to lose its autonomy because he was immobilized for too long time, delirium was not properly prevented or treated, feeding was a problem, falls, urinary incontinence, and iatrogenic drug side effects. And the very important things we have to emphasize is that those causes of hospitalization-associated disability are avoidable. And in neurosurgical ward, we have to be aware of this and take this into consideration. One more time, we need a trend, and we have to work in close collaboration with anesthetists. François Labast is still with us, and he tries to explain the concept, the modern concept of anesthesiology in frail patients. We clearly have to identify the prehabilitation and what happened prior to surgery, the perioperative precautions, and the postoperative rehabilitation. And we have to understand what is this pathway. And you clearly see that neurosurgeons have to be involved prior, during, and after the surgery. Then one more time, we have to zoom out and to understand what is the global process. And for example, promote what is very important is the preoperative optimization. This very good review gives you an overview of what is relevant. This is one more time very simple, but if you look at, if you have a look to your daily practice or to your ward, it probably is very relevant. A patient, you have to be clearly understand what are the parameters we've been mentioned previously, genetic syndromes like frailty, cognition, nutrition, function, cognition, and we need also family support. We have to clearly identify whether the family is involved or the patient is alone. We have to also link with primary care physicians. How can we optimize? And ultimately, how can we optimize the postoperative recovery? Then this is a whole process. And this holistic approach is a key of the successful neurosurgical procedure. We have to be aware, and there are means to improve this, but we have to identify the problem. And we made a lot of progress in neurosurgery, but there are still issues that have to be raised in the older population, and we have to collaborate with specialists. A patient which is operated on needs a collaboration, a close collaboration with anesthetist and surgeon, with a multimodal anesthesia, and try to optimize surgery. What is the optimal consideration? If we have looked to an optimal anesthesia, I'm not an anesthetist, I quote François, and we there is no clear literature that clearly says what is the best anesthetic procedure, but we know that that we have to deliver the very best of what we know at that time. And we know also that taking care of pharmacy, of drugs, reducing pain is really the key issue. And facing the patient, we need a whole process that ultimately leads to an improvement of the pathway and to reduce the side effect of drug in the hospital. Then, in the parallel of what has been done in orthogeriatric, we know that there are pathways that have been characterized and developed. And from this expertise, we submitted in the neurosurgical focus a project. It was chosen as a headline for the first page of the journal, and we tried to explain in our editorial what is the optimal. I'm going to give more details. Here you have an example, a pathway of elderly patients in what I call a neurosurgery, in that most of the wards are like this. A patient is going to see the neurosurgeon that considers he needs to be operated on. This is the anesthetist doing the evaluation. Frailty, social condition is not optimally appreciated. When the patient enters, the gray is the dependence. You see the gray zone of dependence. As soon as the patient enters in the hospital, he starts to lose his autonomy. Then we have to be aware. And usually, neurosurgeon is doing the procedure. We don't actually link. There is no clear, close connection between nurses, anesthetists, and neurosurgeons. And there is not enough collaboration. We don't identify, for example, the goals. How can we optimize the delirium? How can we optimize the pain? How can we optimize the way we handle the restraint on the bed? And there is no clear identification either of the way the patient is actually going and whether he's still autonomous. And when he leaves, when he's discharged from the hospital, usually there is no clear follow-up, and the GP, the physical practitioner, is not sufficiently connected with this process, and a lot of possibility that the patient does not actually recover or regains his autonomy. And although the surgical procedure was perfectly performed, ultimately the patient was not able to be autonomous, and the quality of life is declining. And in order to improve, we propose this geriatric path, neurosurgical pathway. And you clearly see that there is a clear connection between neurosurgeon, anesthetist, and geriatrician. I mean that the culture is to identify frailty and other syndromes that are being described previously. We also strongly believe that a nurse practitioner might be relevant to organize prior to hospitalization the optimal identify patients with red flags, and in order to create a pathway dedicated, tailored to the patient. When the patient entered, you clearly see that the objective is to reduce the gray zone of loss of autonomy. You see the gray zone is trying to limit it only here. And there is a clear collaboration, and pre and post-operative surgical intervention are requested in order to optimize. Of course, we don't claim that we need a geriatrician in everyday life, but we have to acculturate. We have to learn, we have to promote, we have to understand that it's knowledgeable, we can understand things, and thanks to this understanding, we can focus the optimal care and targeting to reduce the hospital stay. And when the patient is discharged, the idea is to clearly link the general practitioner with the geriatrician or the nurse practitioner in order to understand whether the patient is going back to his normal autonomic life, if the quality of life is improved, and the collaboration is requested. You see that this geriatric pathway is not a dream. In fact, it's achievable. It's achievable because we just need to be aware of this, to optimize our care and understand whether this trend has to be followed up, and if we can sort of zoom out to take this big picture. And to finalize the take-home message, I have to thank Darren for this title. I like very much advancing the neurosurgical care of all the people. I like very much the title. Then what should we do? First, successful neurosurgery in all the patients is more than a skillfully performed procedure. We need to have realistic and holistic objectives of care, targeting autonomy and quality of life. But to do so, we need to address risk with risk stratification. We need to have decision-making tools, comprehensive genetic assessment. We need also to better know and it is knowledgeable to understand what are the geriatric syndromes and what are the prevention strategies. We have also to identify frailty pre, per, and post-hospitalization. We need a comprehensive pluridisciplinary approach of trained staff. We need also to organize specific pathway and dedicated wards. We need a transdisciplinary research. I think research is very important, both from the fundamental, but also for the clinical research side. And there are a lot of effort to be done and very interesting research to be performed. And ultimately, we have to adapt our skills and knowledge to the aging challenge, because as Helene mentioned, we are facing a major challenge in the coming year. And this big wave, we have not to be afraid of, but understand that it's a great opportunity for neurosurgeons to understand that we can actually alleviate and improve the condition of the daily patient. And we have to be aware that a patient of 85 or 90 years old should be operated on. Age limit is not actually the issue, but we have to be aware of this condition and to advance in our care of other people. Thank you.
Thank you very much, Dr. Schmidt and Dr. Villars. This was a fantastic talks from both of you. I think you really have given us a comprehensive framework to approach the elderly patients. And as you said, neurosurgeons have, at least in my opinion, an obsession of how good they are in terms of surgery, maybe not so much on how to treat the whole patient. In a patient who's young, usually when you do the operation, they have autonomy and they will look after themselves, and they will have lots of families to look after themselves. Whereas, as you really pointed out, that the elderly don't have autonomy, so you have to help them in terms of when they come to the surgery and go out of surgery to aid their autonomy until they gain the autonomy. And it really is an eye-opener in terms of how best to manage a patient, not just a chronic subdural, not just a normal pressure hydrocephalus, not just a tumor. We have a senior neurosurgeons in our panel, and I'll open to everyone. But we have Dr. Dipu Banerjee, past president of the Indian Society of Neurosurgery. Dr. Banerjee, could I please ask your thoughts on the lectures and how the care of older patients could be improved in your view, how we can take it further? Thank you.
Yeah, thank you, Naren. It was a very, very interesting talk by Dr. Schmidt and Helene. I think it's very, very important because as we are seeing more and more elderly patients, and we as a neurosurgeon have so far been only kind of looking at the neurosurgical aspect, but there are so many other things which are happening. I think first thing what I think the first few slides mentioned was more important is that 60-65 years age is no more relevant anywhere. I had a chance to operate 2 patients, and another topic which I thought I will have an opinion from the guests is about subarachnoid hemorrhage and aneurysmal, because both the patients were 75, 80, and there was a little bit dilemma because intervention was not possible because of very tortuous vessels and surgical risk. And then I looked into the literature of Korea and Japan, where they're freely operating patients at the age of 90. And there's a huge number of studies of patients on subarachnoid hemorrhage. Also, another factor which we face is quite common, which we generally don't look so often, is the sodium imbalance. A lot of patients we find post-op day 2, 3 is going down and down, and we keep on looking for everything else, scan, MRI, and other thing, and they finally found that the sodium has gone down. I think it needs a lot of efforts, and Dr. Schmidt has really comprehensively covered most of the areas from social to legal to ethical, and of course technical with nursing care, physiotherapist, ortho, everything. But if I look it from Indian perspective, we had wide population from different socioeconomic status. There are problem with housing, where maybe people are living in a very small house in certain places, or resources are there. Post-operative care is very important. We can operate a patient, good outcome, but the rehab is not possible. So I think every country has its own problem, but overall, I think it needs I would say that it would need even a longer session sometimes in future. Thank you so much.
Thank you very much, Dr. Banerjee. Can I, Dr. Schmidt and Dr. Villars, do you have any thoughts on the comments of Dr. Banerjee? Thanks.
Thank you. I think you're raising. I didn't want to mention aneurysms because it's a very rather peculiar topic. But one more time, as you clearly explained, in literature or in various teams, what is the age limit? And the problem is then when you lose the grasp of reality because you only focus your own approach. What is, for example, facing this problem of aneurysm, we need, in fact, to collaborate with other people. You should not retreat or to refuse a treatment because you consider that it is not, depending on the age solely, that you reject this option. We have to sort of tailor neurosurgical approach. The very important thing for me is to understand what is the geriatric condition and what is the neurosurgical condition. Can we combine? And if a patient, which is 80 years old, has a good geriatric condition and the profile of the aneurysm is to be kept, then why should we reduce or reject this project or don't step further? Since there are possibilities to treat. We need to, as I said previously, to take a larger frame and understand what are the characteristics. You mentioned India, where there is a huge diversity of social care and social systems. But one more time, try to fit to the reality and take some distance. That's more or less the core of the message. Try to combine expertise and better characterize the reality, what actually how the patient behaves. Especially we show this nice graph. Let's show the nice graph of stress and a frail patient has to be is more endangered facing a reality than using tools to identify frailty, tools to identify new concepts like this to be very relevant in neurosurgery. It could be even in India, it could be very relevant to develop expertise like this.
Yeah. Thank you. Thank you so much.
Thank you very much. Dr. Malin, do you want to ask a question yourself, Dr. Malin? So I'll read out the question that Dr. Jeffrey Malin from Malaysia has put is, what's the training program for geriatric neurosurgery? Should it be a subspecialty? And how long and what posting should be undergone? Thanks.
This is a big issue. Whether we can, if we compare, for example, I made the comparison with pediatric neurosurgery, which is well trained, there are lots of staff. It's a brand new subspecialty neurosurgery, geriatric neurosurgery. But if you face one more time of the reality of the department, you clearly see there are needs to do this and to optimize the care. And there are probably needs to better characterize, depending on the skill and interest of various neurosurgeons. Maybe we have to consider training. I don't have precise idea, but I think there are possibilities to define a training program, because young neurosurgeons have to be aware of it. They have to understand what is the reality, what is a frail patient. And of course, when a young trainee, I know them, when they see a posterior fossa meningioma, they're really excited. But we have to, it's the experience of neurosurgeon that says, okay, calm down. What is the target? It's like when you perform a surgery, at a certain time, you have to say, we have to stop. And this is experience. And I'm pretty sure we all have this experience that we became wise with age. We grow old, and it's a good thing. But this expertise has to be expressed in various ways. It's an experienced neurosurgeon is the one which is able to perform a skillfully procedure, but also knows when to start and especially how to manage complications. And this is what we experience one more time in our everyday life. When we gain experience, we understand, and we have to teach this. We have to understand what is our intrinsic capacity, the ability to characterize a condition, to take this big frame. Well, right, I said it many times, but this is an important issue. And in the department, there are always neurosurgeons interested in sort of zooming out and trying to give the very best, and to create an adequacy between what is needed and what has to be done. And this is a sort of a subtle process. This is not straightforward. This is not clip or no clip, go, no go. This is complexity management. This is a aging process, which is what we all face. And as I mentioned previously, in terms of humanity, is very important, because taking care of the fragile one, taking care of the one which are not actually the most interesting. I know draining a subdural or inserting a VP shot is not always very exciting. But from my perspective, my goal, and as mentioned, I really like your presentation, are fruitful. When we are fruitful, and when the patient actually improves in a daily life, and the fact that you demonstrate that shunting a patient dramatically changes his daily life is a very good example. And then we have to focus. We need, of course, experts in skull base, we need experts in vascular, but we need also experts in geriatric neurosurgery to conceptualize and to bring light to this particular condition.
Thank you very much, Dr. Schmidt. Just before I bring Dr. Kalia Perumal, he's a neurosurgeon in Edinburgh, I just wanted to ask a question to Dr. Villars. Dr. Villars, geriatricians are already very short in supply. They already have a very busy, there are few geriatricians per the number of geriatric patients. And the geriatric care itself, I might not have the full facts, but I always feel that it's not fully as well as supported as a acute cardiology or acute respiratory medicine. And when you have how do you then get the good quality geriatric care for neurosurgery when already geriatrics itself is overstretched? That's my thought. Thanks.
Thank you for your question. It is true that we are not enough to be in collaboration in the neurosurgical wards. So that's why this acculturation and this sharing of experience and of knowledge is very important. And that's why the training process is very important, because we cannot be one surgeon, one geriatrician, one anesthesiologist around the patient, We need to share our culture, the concept, the geriatric syndrome, frailty, normal aging, everything, because it's a problem of public health because of the number of persons, because of aging of the population. We need to share and we cannot assume alone this. Unfortunately, of course, even if we try to train more young geriatricians, of course, around the world, and it's a new discipline that now can have some positive aspects for young physicians, but we are not enough.
To step further, I think that practitioner nurses could be a very good support also, because there are concepts, there are tools, and nurse practitioner can be very helpful in order to teach, to optimize the care, and to be dedicated before, during, and after the hospital stay. And we have to, the geriatric care needs, of course, medical care, but also sort of a more practical help. How can you deal with the delirium? How can you deal with urinary tube? How can you deal with pressure? With advanced nursing can be very helpful, and it can be sort of developed, or it can be spread, and it's really straightforward. For example, I'm considering, we are in the process of writing a paper about hospitalization-associated disability in neurosurgery. And for example, we want to add to this paper posters that can be put on the walls of the wards. And exactly what you've seen previously, we showed this, we want to translate it in various languages in order to understand. It's straightforward, it's not very complex, and it is achievable in daily life. You can tomorrow can decide to slightly shift your culture, the culture of your department, toward the geriatric culture. I'm not a geriatrician, I'm a geriatric neurosurgeon, but I'm not geriatrician. Almost, yes, but I skipped to my surgical culture. But I understood, as when you understand a procedure, you understand how to slightly bend the inclinate or slightly change the system. And when you discuss with the nurses, with other doctors, with the patient, the family, you can slightly bend the system towards a more, I would say, age-friendly department. Because most of our departments are not age-friendly. Consider a patient which is 80 years old that enters, you have to make all these electronic procedures, it's a lot of stress, and it's complex. We can help and sort of slightly change the trend. It's a slow process. Of course, we need training, we need devices, tools, concepts, but it is achievable in daily life, in every department of neurosurgery worldwide. This is why it's so important. It's not like rocket science or very expensive systems. No, you got very skillful neurosurgeons, but you need to understand what are the optimal way to take care of elderly in every department, irrespective of the place you are. In India, in Uganda, but also in Toulouse, in New York, or in Bristol. It means that there are trends that can be changed, but we have to be aware of this and understand, create a network, create a network of people, of neurosurgeons interested with geriatricians, with anesthetists, with people from ethics, and try to transform this concept to a reality. And this is not far from reach. This is an achievable goal.
Thank you very much. I think you make an absolutely important point. It's not a rocket science, but these are achievable, and it just takes, interest and effort to put it on. I think sometimes you can achieve, everyone likes a glamorous thing, but actually sometimes you can achieve much greater with a care that achieves more. Mr. Kalia Perumal from Edinburgh, can I please invite you to comment and your question for the panel, please?
Yeah. Can you hear me?
Yes, yeah. Absolutely.
Yes. Hi, thank you, Dr. Schmidt. It's a very nice talk. I had some internet connection problems, so I couldn't listen to some part of the story. I completely agree. Neurosurgical specialty, if you consider pediatric neurosurgery, I see geriatric neurosurgery. It's just an extension, but in a different format. So if you look at the actual surgical technique, nothing is going to be drastically different. But as you exactly pointed out, the frailty score is very important to determine who is going to do well and who is going to rehabilitate quicker compared to another geriatric age group patient. So I think, having that teamwork transspecialty is a nicely worded, sort of phrase. I think a neurosurgeon working with the rehab team and a geriatric physician on board, you can actually achieve much things in a very smooth and in a very standardized way. We are in Edinburgh. We are just trying to look into a concept of enhanced recovery after cranial surgery. Enhanced recovery is very well known in GI surgery, orthopedic spine surgery, even, but not in cranial surgery. So I think frailty score was very important when we looked at that, because it's not just about doing an operation, but just getting the patient safely out of the system, but in a better state. So I think there's lots of work, and I'm looking forward to your publication in the future. And it's about job opportunities. If we say that we're advertising for 5 geriatric neurosurgeons, I'm sure there'll be plenty of people who'll be focused in getting geriatric neurosurgical jobs. So I think this is an evolving thing, and I think there is more way to go. This is an aging population. What we are treating now is not middle age; it's more 70 is a new 60 and a new 50. So thank you so much. Thanks for the lovely talk.
Thank you very much, Mr. Kaya. Do you have any comments, Dr. Schmidt and Dr. Villars, on?
Yes, I agree. And promoting geriatric neurosurgery, let's be clear, is cost effective. In terms of health economics, we have to demonstrate it. But there is already a literature that clearly supports it. And if you want to promote this in your department, we have to define a framework to demonstrate the people in charge of the health economics in your hospital that better care is cheaper and it's more efficient. And this has to be clearly identified. The cost effectiveness of geriatric neurosurgery has to be promoted. This is not to spend more in order to have an hypothetical improved care, but in the daily life to deliver improved care, reduce length of stay, improve autonomy and quality of life. And this is a major challenge for neurosurgery and a fantastic project for my specialty.
That's brilliant. Thank you very much. I think in terms of, when the policymakers see that it is the economically beneficial, I think it will change. And also nowadays, the elderly patients are also more powerful because they are not as frail and as before, and they are economically powerful. If you look at in Britain, the amount of the percentage of population which has houses, the elderly are the ones that are increasing in numbers, and they are politically more powerful as well. I have sent the circulars for these lectures to the president of the WFNS, to the president of the American Association of Neurosurgery, the president of the EANS, president of the African Association of Neurosurgery, the president of the EANS, Mr. Dimitriadis, was here for most of the talk, and I hope they will take this concept and have a geriatric section and try to push this through. And my hope is that in November we will have a symposium on geriatric neurosurgery. What I will try to do is I will of course contact Dr. Schmidt and Dr. Villars and all those who have attended this meeting. I will have a discussion with you and try to get the charities, the age, the elderly age in Britain. We have got a charity for aging population, which is extremely politically powerful, and try to get some politician to come as well and get the EANS and WFNS to come as well and